So, these are some more practical questions, Dr. Abdullah. One question is, do you recommend that everyone take a baby aspirin daily to prevent stroke and cardiac arrest?
No. So aspirin thins your blood. And I explained to you in one of the slides that you have blockages in your arteries and suddenly you form a clot on it. So what was 30% blockage suddenly becomes 100% blockage within a minute. Or what was 75% blockage becomes 100%. So it's the clot that ultimately causes a stroke or the heart attack. So you want to thin your blood so it doesn't clot easily. And aspirin is one of those medications you use to not. But you want people who should take the aspirin are people who have the likelihood of developing a clot on top of their blockage, not people who are healthy and who are well and who've never had blockages, who've never had a heart attack, or who are relatively young or middle age, who have no risk factors. So it all depends on the risk benefit ratio. If you are relatively young, you don't have risk factors of smoking, high blood pressure, diabetes, you have activity regularly, not exercise. Exercise is bad thoughts. Activity with good thoughts and silencing your mind. Then you're unlikely to form the clot. So taking aspirin is going to be more risky to you because it thins your blood too much and you may start bleeding from your stomach or in your brain or something. So it's a risk benefit ratio. On the other hand, somebody's already had a heart attack, they have blockages, and they are taking medications or they have risk factors. They're older, they have diabetes, then they should take a blood thinner and prevent that clot from, because in their situation, the likelihood of forming a clot on an underlying blockage is very high. So those people should take aspirin? No. So your doctor should individualize the care. He or she should understand your status, what risk level you are at, and then determine whether you should take aspirin every day or not.
So, if you have high blood pressure, for example, should you take an aspirin? One of our listeners is asking.
So this is actually a very good question. And she used a very interesting risk factor, hypertension, not smoking or diabetes or this or that. Okay, so let me tell you a little bit about hypertension. So let's say the person has essentially just high blood pressure and otherwise has no risk factors, no heart disease, no previous heart attack. So it just has high blood pressure and therefore should she take aspirin every day? Now, leave that thought for a second. Come to this side and think about high blood pressure. High blood pressure can cause hardening of the arteries, which can lead to a stroke because you form a clot on top of it. So, high blood pressure is a major risk factor for stroke. But high blood pressure also causes a stroke because you get bleeding in your heart, in your brain. The small blood vessels can rupture due to the high blood pressure. You can bleed and you can get a hemorrhagic stroke as opposed to an ischemic stroke, a blockage stroke, or a bleeding stroke. And now, if you're taking aspirin, you're going to more likely bleed and have a bigger hemorrhage in your brain, and it can be worse. So, with just one risk factor of high blood pressure, your risk profile is still very low. And you should really think twice about taking aspirin. Now, on the other hand, if you had one risk factor, diabetes, then the risk of thrombotic, blockage heart attacks, or blockage strokes is quite high. And you're not at risk of bleeding. Then maybe you should take the aspirin. You see the point? That's right. कोई change diabetes बहुत खराब है सच्ची बात
The other question, I have some questions from people about cholesterol.
Okay.
At what point or at what level of LDL should you start medication?
Good. Okay. You know, there are general recommendations and then there is what an individual should do, how the doctor should treat you, the person who is in front of him or her in the office, and what are the recommendations for all groups of people. So you got to separate these two issues. When you look at groups of people, it is very important to lower your cholesterol, because if you look at groups of people, people who have higher cholesterol levels tend to get more heart attacks. People who have lower cholesterol levels don't get not more likely to get heart attack. So we always talk about lowering your cholesterol. So on the other hand is the risk that you already have, right? So if you have already had a heart attack, or if you have known to have blockages, or if you have had a minor stroke already but recovered fully, then you are at very high risk of getting a recurrent event. So that is called secondary prevention. Whereas the person who has never had a stroke, who doesn't have major risk factors or may have cholesterol as a risk factor, is not at that higher risk of getting the problem. That's called primary prevention. So yes, you want to do primary prevention so people do not get this heart attack problem. But secondary prevention is critical. So an LDL cholesterol of 3, you think the person who's already had heart trouble and is now trying to prevent a secondary event, is that good enough? Or the cholesterol of 3 for someone who is doing primary prevention and is not at that much risk of having an event, but is at risk, is 3 going to be okay? If 3 is okay for the primary prevention person, 3 is definitely not okay for the secondary prevention. So he needs to get, or she needs to get her cholesterol below 2, and the real figure is 1.8. And now we are learning that doesn't matter 1.8. The lower, even if you get to 1.4, 1.2, you still keep getting benefits of not getting a recurrent event, particularly if you are at high risk. So the number is variable based on who you are, based on your risk. But for the general population, we like to keep the LDL below 3, especially if you've not had a problem. But if you are at high risk, your family history, your father died of a heart attack at the age of 55 or something like that, you are South Asian, you're already at high risk being a South Asian. I mean, and diabetes, God, I mean, you're in the high risk range. You should have your cholesterol well below 2, and lower the better. And therefore, to bring your cholesterol down below 2, it's going to be very difficult with activity and nutrition. I don't call it exercise and diet. I call it activity and nutrition, the positive way of looking at it. It's very difficult. When we are born, our LDL cholesterol is 1.0. That's what the universe or the Lord or Allah decided is what the human body needs. The human body needs a cholesterol of LDL of 1.0, from which we make cell membranes, we make sex hormones, all of those things need cholesterol to be made. And 1.0 is enough. As we live in our world, and as our diet changes, and we have bad nutrition or we don't do good activity, then we begin to have a rise in our LDL cholesterol level. And then some people have a genetic disorder where they have this tendency to make too much cholesterol inside their body, and they can have an extremely high LDL cholesterol level. So those people, and many who are at high risk, will need medication. And the best medication today is statins. But there are newer medications now coming, and I'm giving a talk at an international conference on the 21st of this month, and talking about these newer medications for cholesterol lowering beyond statins. So again, it's an individualized situation, but in most cases where there is this very important need to lower your cholesterol, then you will need medications.
Great. Shiraz, you had a question, I believe. If you can unmute, you're welcome to ask. Maybe Shiraz did.
Is it me?
Yes.
Yeah.
Okay. Yalimada, Dr. Saib. My question is that I am a patient. I had a heart problem and a bypass for now is 5 years. And these 5 years, I'm not able to get the itchiness out from my chest. And I've used all kind of lotions, and I don't know how to get rid of it. And it bothers me a lot, so I don't know what to do about it.
Well, when we do bypass surgery, we actually cut the bone. We actually use a saw, electric saw, and we cut the breastbone right down the middle. And we cut the muscle even further down and further up right to the top of the neck. That's why you have this long scar. But now we can do it with smaller scars. But essentially, in everybody, it's this big scar, and we've cut the. When we cut through the skin, the tissue, and the bone, there are always nerve endings in our skin and under our skin, and we cut those nerves. So when we put that chest together, we use wire sutures. We actually use wires. We put a wire from one side, bring it out from the other side of the bone through a hole, and then we twist the wire and stick it into the bone, and that's what we use, wire sutures. Now there are some nylon sutures that also work, but the wire sutures are the best, and they work the best. And so you had that done to you, and you have those wire sutures, and that brings the bone together. It takes 2 or 3 months for that bone to heal. Therefore, we explain to you not to golf and use your arms too much or do heavy exercise or lifting for 2 or 3 months to allow that bone to have healed properly. The tissue and the skin heals quickly in a few days, in a week or 10 days, it heals. The nerves that are cut take a long time to heal, and they grow. The sensation some people get. Now, this is the limbic system. This is the emotional brain, okay? The sensation that people get is different in everybody. Some people don't feel it at all. The nerves grow, they get grown, 2 or 3 years have passed and everything's fine. Some people feel what we call hyperesthesia. When you put your sheet or you wear your shirt or you touch on it, then it's very uncomfortable. It's very sensitive. That's called hyperesthesia. Some people get paresthesia, which is what you have. They have abnormal sensation. And this abnormal sensation is bothersome. And one of the abnormal sensations, it could be a feeling of feeling very cold. That part of the chest always feels cold, or it always feels hot or warm, or in your case, it always feels itchy. Now, there is no infection, there is no rash. It is a sensation and a problem of the mind. And the nerves are growing. Many people, the nerves are growing, the mind is unable to perceive that. All right? So I will tell you 2 things. No creams, no vitamin E. Vitamin E helps for the keloid, that heavy scar. Cortisone, creams, nothing works for this paresthesia. Because the problem is not here. The problem is here. You with me?
Yeah.
Unless you can get into your brain and put cortisone cream on that limbic system, I don't think it's going to work. So 2 things I would advise you. First, understand this situation and understand that it's a state of mind. And then try to train that mind differently. You are alive today, 5 years later after your bypass surgery. Just think about it. Are you grateful about it? Are you happy? Is your family happy to have you around? Are you still the breadwinner? Are you enjoying life and traveling around the world and doing things because of that bypass surgery? The tiny price you have paid, is your brain's kind of gone crazy and it feels itching.
Mm.
That itch will not bother you that much if you have the right state of mind.
I see.
Concentrate on the big benefits, the gratitude. All right.
Okay.
And the second thing is patience. Have patience. The nerves take a long time to grow, 2, 3, 4 years sometimes. And then they slowly grow, and there will come a time, and then you will suddenly say to yourself, oh my God, that itching is gone. So it's a time. You are unfortunate. It's gone on for 5 years. You're one of the most unusual cases that I've heard. Most usually go away within a year or two. So that's what it is about. All right.
Thank you very much, Dr. Saib. Thank you.
Dr. Abdulla, can you speak about the relationship between LDL and HDL cholesterol? You spoke about LDL and the number that one should be targeting. What about HDL?
Okay. I have a talk on that on my YouTube. You go to my YouTube, Dr. Abdulla, cardiologist, and I have all these talks about cholesterol and other things about heart disease, and you can watch. And people have asked this very question, and I have an answer on the YouTube on this very question. So what is the answer? LDL is the cholesterol that's carried on a protein particle called ApoB. So it is a ApoB connected cholesterol. All right. The cholesterol on HDL is the same exact cholesterol, but it is connected to a different particle. Its mate is different. The spouse is different. It's an ApoA particle. And anything starting with an A, is very, very good. Never harm you. So that cholesterol that's connected to the ApoA particle is not harmful, does not cause blockages. Whereas the cholesterol, which is the same cholesterol, attached to ApoB, is able to get into the lining of your arteries and start the process of the hardening of the arteries. So higher your LDL cholesterol, which is the same cholesterol, then higher your risk of getting blockages. Lower your HDL cholesterol, then it also increases your risk because you don't have enough good cholesterol to protect you. The good cholesterol takes the cholesterol out of the artery, takes it back to the liver, and excretes it in your bile. But if you have a lot of good cholesterol, it's the same cholesterol, it's just attached to the good protein, which is ApoA, then you are protected. It tends to protect you from the hardening of the arteries. Women generally have higher HDL cholesterols than men. And this is why women have lower incidence of heart disease compared to men. But still, it is still the number one killer in women as well. And if you do activity with the right state of mind, your HDL cholesterol goes up. You can get your HDL cholesterol up by drinking alcohol. You can drink wine, you can drink beer, and it raises your HDL cholesterol. It's the wrong HDL. There are many, many HDL particles in your blood. The HDL particles that are raised by alcohol provide zero protection to your arteries of the heart. It's well proven. There's one study 2 decades ago about red wine that everybody keeps quoting has been disproven many, many, many times in the last decade or so. So this is the relationship about gender with good and bad cholesterol. And so it's a ratio. You want to have as much good cholesterol as possible, and you want to have as much bad cholesterol. So it's a risk predictor. HDL cholesterol is a risk predictor. High HDL, lower risk. Low HDL, lower risk. So it's a risk predictor. Whereas LDL is more than a risk predictor. Higher the risk, higher the LDL, higher the risk. Lower the LDL, lower the risk. But LDL is actually involved in the chemical process in the lining of your artery to actually cause the hardening of the artery, and that blockage has cholesterol in it, which is LDL cholesterol. So the LDL cholesterol has a risk prediction attribute, So does the HDL have a risk prediction attribute, but the LDL is also causally related in causing the hardening of the arteries. You get that? It's a combined function.
Okay, Jasmine has a question.
Yani Madad,
Mola Ali Madad.
I just had a quick question. Heartbeats per minute, if you can talk on that a little bit more. What's lowest at resting point, and even at resting point, if it's high, what that means, and how can one control that? And I did have another question, but it slipped my mind, but I'll let you answer this one first.
Thank goodness. Okay, because this is a tough enough one. All right. So I presume you're asking about heartbeat, your resting heart rate, correct?
Yes, yes.
Okay. So there are many, many studies done in the literature which show that people who have lower heart rate live longer. People who generally have high heart rates when they are resting, like when we are sitting, relaxing, some people have a higher heart rate, 70 or 75 or 62 or something. Some people who are resting, sitting, relaxing have a lower heart rate, 50, 52, 48. Those people live longer. So there is a relationship between longevity, heart disease, and resting heart rate. This relationship is even more important when you already have a heart problem. So we use these beta blocker medications to slow your heartbeat even further. And we like to keep your heartbeat below 60 when you're resting, preferably around 50, preferably around 48. So one of the reasons these beta blocker medications are used is to keep your resting heart rate down. So there is this very important relationship between resting heart rate and. Now I ask you, if you were to put a monitor on Nimi, and Nimi now goes to the mosque, to Jamaat Khana, and goes for meditation session at 4 o'clock in the morning. And she's meditating and gets deep into her meditation. And this heart rate monitor is on. You think her heart rate will be 75 or will it be 48?
48.
Right on. So silencing the mind silences the heart. You with me?
Yes.
The strong connection. When you relax, you should relax. When you go for a walk, stop gossiping with your partner that you're walking with. Stop complaining about your husband. I mean, all husbands are bad. We know that. This is why I don't like men. I only like women. Anyway. But so it's the state of mind that is important. You should train yourself, control your mind. Your mind is the powerful organ. All
Okay,
right.
I remembered my question. I
Oh,
was
no.
wondering, does arthritis affect our heart? That's one question. And the last one, when we are masking, let's say for 2 hours or up to 8 hours, does that have an impact as well on our heart? So those were the last two questions I had.
Okay. Since
Thank
your
you.
question was very long, I'm going to give a short answer. Only the type of arthritis that is related to autoimmune disease, like scleroderma or lupus, those arthritis types cause in women, which are more, this disease are more autoimmune disease, more common in women. And in women, they cause premature coronary artery disease. So women who have lupus, who have scleroderma and stuff, get hardening of the arteries much earlier than women who don't have. So that's the only arthritis that is of importance. And a second question was about masking. What was that?
Masking, I mean, it can be as short as 1 hour, anywhere to 8 hours. People who are working at stores such as maybe
Oh, masking never hurt anybody. Okay. Yeah. Look, I worked for over 3 decades in the operating room and in the cardiac cath lab, doing procedures, wearing a mask from morning till night, and sometimes many emergency cases in the night, wearing a mask all the time. Masking never hurts anybody. I'll tell you about the mask. The mask prevents the droplets that come out of your mouth. While I'm talking to you, my computer screen has thousands of droplets, tiny little droplets droplets that have come through my mouth and are now floating in the air, who are called aerosol, and have settled on the computer screen. If they settle on your lips or on your nostril, and if that droplet contains the COVID virus, then you're going to get it. You with me?
Yes.
So the mask that you wear protects the other person from your droplets. And the mask she wears protects you from her droplets. So the reason you wear a mask is your civic duty, your civic responsibility to not, if you don't even know that you may be carrying some germs, to not give it to others. That's why you wear a mask. If you don't feel you have that responsibility, don't wear it. Complain about it. Say it bothers you. But if you are a responsible human being who cares about your brother, your family members, or your co-workers, then please wear a mask, because that it protects others. And she wears a mask, so it protects me. The mask very poorly protects yourself, because you get things getting in from the side, you touch the mask, then you touch your face, the COVID virus goes into your eyes, nostrils, and mouth. It has 5 portals, 2 eyes, 2 nostrils, and a mouth. So you're wearing a mask, but it can get into your eyes, into the conjunctiva and stuff. So the mask very poorly protects you, but maximally protects other people. And that's the whole story about. Stop complaining about the mask. Wear the damn thing. Protect others.
Dr. Abdulla, we have time for 2 more questions, and I have both of these on chat, so I'm going to ask them to you. The first question is from an individual who suffers from low sodium and high blood pressure. And so their challenge is that if they were to increase their salt intake, it might also increase their blood pressure. Do you have any suggestions for someone in this predicament?
Okay. So it's a long talk, but I'm going to try and summarize it. If you are Chinese, if you are a black human being, if you're a white human being, then the salt in your diet is going to impact you differently because of your genetic makeup and because of your arteries. So some cultures, when they have salt in their diet, their blood pressure goes up. And some cultures are not so sensitive to salt, and they don't have much relationship with their diet. So, the Chinese did a study which was published last year of over 22,000 people, and they let them use the salt normally, but they switched the salt to the low salt, which is more potassium chloride than sodium chloride. And they had a dramatic drop in stroke rates within 5 years in that whole village that they did this study in. In China, the villages are 20,000 people and more. Anyway, so there is a cultural sensitivity to salt. We, South Asians, have a very little salt sensitivity. So we don't have much interplay between salt in our diet and high blood pressure. But we have a big interplay between salt in our diet and heart failure and retaining fluid and fluid overload. So salt is bad for us too. So that's the first thing you should know about salt. Now, if somebody has low salt, the only way they found out that they have low salt is somebody did a blood test and they measured the electrolytes and the sodium was low. Well, the sodium is a concentration of the milliequivalents of sodium in 1 liter of blood, or milligrams of sodium in 100 mLs of blood. It's a concentration. So 140 is about the normal, but you have a sodium of 132, the concentration is low. You could have more fluid than salt, then your concentration drops. Or if you have more salt and less fluid, you're dehydrated, your sodium level goes up. So it's a concentration. But your total body sodium could be extremely high, even though you have a sodium concentration of 132, right? So when you measure the sodium in your blood, it has no bearing to your total body sodium level. And therefore, taking salt intake to improve your sodium level is of absolutely the wrong thing to do. You will develop leg swelling, edema, and you may go into heart failure. There may be a fluid overload problem, that there is more water than salt and your concentration drop and you are fluid overloaded. And now you take salt in, you actually get into more trouble. So please don't try to treat yourself based on the blood test, which is a completely different thing. That's a concentration. It's not giving you the total body sodium load that you are carrying. All right. There is only one condition in which we give salt and give intravenous sodium chloride to heart patients, and that's the syndrome of diabetes insipidus, which is not the regular diabetes. Again, the brain has gone haywire and produces too much ADH, which is antidiuretic hormone, and that's a feature of another talk. Thank you.
I have one last question for you, and then we'll end, and that is, do people do preventative angiographies to see if they have blockages in the heart?
Okay. The simple answer is no. It's a bad thing, because angiography is not without risk. I mean, you have the risk of causing an arrhythmia. You can knock off a little clot, speck of hardening of the artery from the aorta. It could fly off into your brain. You could get a stroke. You could bleed from the artery where we go put the catheter. We could perforate the artery when we are in there. You could die. I mean, these are rare complications, but they occur in 1 to 2% of people. The bleeding occurs in maybe 5% of people. But to that one person who got a stroke, it's 100%. And you don't know if you're going to be that 1 in 1,000. So you don't want to go out there and go willy-nilly and say, oh, could you do my angiogram? I want to see if I have blockages. The anatomy of the arteries is important, whether there are blockages or not. But the functional effect of that blockage is equally more important. And therefore, just treating the blockage does not always prolong life or prevent heart attacks. But the other treatment that goes along with that angiography is what prevents heart attacks and strokes. So who should have an angiogram? The person who should have an angiogram is a person where the doctor suspects that he or she has severe blockages in there. They're having symptoms, they have had a stress test that's abnormal, they may have had a nuclear scan, a MIBI scan, or so that the scan shows that there are potential serious blockages. So those people need it for the diagnosis. The other people who need it is for secondary prevention, where we know that they have blockages, they've had a heart attack, and now they're having recurrent symptoms, or there's recurrent problem, then we have to repeat the angiogram and then make a decision what needs to be done. But nowadays we have another test, which is called CT angiogram, coronary CT angiogram, which is done with a CT scan, takes about 2 minutes. You don't even have to take off your blouse or your shirt. You get on the table, the CT scan is done, and a dye is injected into your vein, and no catheter is put up to the heart, and we can now see the arteries of the heart. So we use this now more for diagnosis and also for reassessment to see if something major needs to be done. Then we'll do the regular invasive angiogram and the stent or whatever. So there are indications for who should have an angiogram, but a preventative angiogram is not an indication.
Okay, thank you. Mom.
Yeah, Limadat.
Go ahead, Mom.
Yeah, Limadat, everybody. Dr. Abdulla, I hope this does not give you, you are not emotionally stressed out with this presentation.
No, this is stress that doesn't harm you.
Okay.
This is stress where you feel good, you are enjoying preparing for this and sharing knowledge. This stress is not harmful. But there is harmful stress, and I told you the 2 types of stress which are very harmful: the work stress of middle management and stress related to emotion. When it's stress related to your mate, to your family members, to your children,
Correct.
that stress is a killer.
Okay. So hope you don't get that.
No, I have the perfect wife. We call
All
her
right.
Kia Pop. K-I-A-P-O-P. Know it all, Princess of Perfection.
Okay, on behalf of the Ottawa Jumbo team, I would like to thank you for a wonderful it was a wonderful presentation, Dr. Abdulla. We all benefited your insights a great deal. We really enjoyed it. Thank you, Dr. Abdulla, for taking time of your busy schedule and sharing your knowledge with us. There was quite a few difficult questions and you answered them all. It was very good. Being in Vancouver, the time difference, today's presentation certainly breaks into your routine and you're accommodating our schedule, for which we are very grateful. This has been an informative session, especially for the women listening to today's presentation. As we continue to assume heart disease is more for male. Well, thank you shedding light on this important subject. Very good. Thank you very much once again. Thank you all. And thanks for joining. Give him a big round of applause. Give him a big round of applause.